All right. So welcome. This is session two, Healing Roots, Embracing Culturally Responsive Care for Providers and Consumers. This session will be facilitated by Dr. Anitra Warrior. So I'm going to hand it over to her and allow her to introduce herself.
Okay, thanks again for attending. If you did come to the presentation that I did yesterday, you'll see a lot of similarities between what we discussed yesterday and what we'll discuss today, but we will go into a few more practical steps that you can take as we talk about embracing culturally responsive care for providers and consumers. So, we do need to state that there are no additional disclosures for this, so making sure that we cover that as well as recognizing that this September is National Recovery Month. Recovery is for everyone, every person, every family, every community. Okay, so as she mentioned, my name is Anitra Warrior, and I'm a psychologist who's based out of Lincoln, Nebraska. So very happy to be here and share some of the experiences that I have as a clinician, as an owner of a private practice, and someone who really focuses on serving marginalized populations. So we're going to talk about specifically with our indigenous populations or American Indian, Alaska Native American. We're going to talk specifically about the work that we do on those reservations. So as I begin, what I think is important to share, and this is a cultural response or a way that we would introduce ourselves. So it would be telling you that my name's Anitra Warrior. I'm from the Ponca tribe of Oklahoma. I'm also from the Blood Clan. Within our tribe, the Blood Clan is someone who each clan within a tribe has roles, and that's how our community survives. Within my clan, our role is almost like you could kind of define them as police. So we're kind of like taking care of our tribes. We watch out for what's happening within our people. We're kind of those protectors. So that's what clan I come from through my grandfather's side. I have all of these wonderful roles as a daughter, sister, mother, aunt, and my greatest role is that of a grandmother. This is my first granddaughter. Her name is Logan Morningstar, and she is she's amazing. And so that again, just my greatest role is being a grandmother and having all of these amazing relationships that I have with my family. My personal interest in psychology, I think, is really important to share because what I disclose is my experience as a consumer of behavioral health services, but then also that as a provider of behavioral health services. So it's me moving into this career was based on a very personal event that I had also shared yesterday. But so I'm originally from Oklahoma. That's where my tribe is from. And not originally, but that's where we were relocated. And so as a young adult, I had moved to Oklahoma City. And so throughout that area, essentially all of Oklahoma would be considered Tornado Alley. And so as a young single mother, I had three children. My oldest was four. And on May 3rd, of 1999, we had a tornado that came through and completely wiped out significant portions of Oklahoma, pulling trees out. I mean, I think the winds were clocked at like 318 miles per hour. So it was very severe. We lost 42 people in that tornado, and my oldest daughter was one of them. And so as you could imagine, as a single mother, it was just real, and for any mother, for any parent, it was really difficult moving beyond the grief and the guilt that I carried. And I almost became consumed with it and really struggled to find a good way to heal. And I shouldn't even say heal, I should say adapt to what my new life is going to be or has turned into. And so I started working with therapists. worked with a therapist to do CBT, to do EMDR, to do Christian counseling. And one, I still, even as a psychologist, I don't know what orientation she was using with our work together. But what I had found in my experiences was that it was actually not a safe environment for me to work with these therapists. The reason why is because anytime I would disclose my cultural beliefs and how that would assist me in my grieving process, it was pathologized. If I talked about experiences that were happening in my home, spiritual experiences, then it was okay. We need to take a look at reviewing your medication to see what's going to be the most effective, because these are hallucinations. This is not real, but actually, yes, it was real. This is my belief. This is what I know to happen for my people. But my entire culture ended up being pathologized. That's not okay. That's not safe. That's not going to help us heal if we can't be our true, authentic selves in the counseling session. So I ended up at that point deciding I'm going to be a psychologist. I'm going to start my own clinics, and I'm going to train people to work appropriately and provide culturally responsive care. And so at this point, I have Morningstar Counseling and Consultation. We have 7 clinics. We are located in Lincoln, Nebraska, Beatrice, which is a small rural town, and then we're located on the reservations in throughout the state. And so we provide statewide services, and we were doing that through telehealth even before the pandemic. So really doing all that we can to reach marginalized populations. So that's the history of how we got started, and explaining again my experience as a consumer and the route that we've taken as clinicians and providers. So today, we're going to go through kind of the overview, and then we'll talk quickly about the objectives, but we're going to be talking about cultural competence. And what I think is so important for us to remember is that this is not the best term when we say cultural competence, because we never actually meet cultural competence, okay? That's just not possible. There's too many within group differences, between group differences. And when we think about cultures that have had so much that was lost that they're holding on to, you're going to see those within group differences be even stronger. And there can sometimes be misconceptions about what that is. So cultural competence is not a true term that we aspire to, but cultural humility is what we're going to really reference. Now, for my slides, you will see that I continue to use that term. And that's because for the research that I've pulled from, these are the terms that they use, but I'm going to keep saying cultural humility, but I don't want to change someone else's words. We'll talk about culturally informed and responsive care, identifying community norms. Excuse me. And then practical steps for working with Indigenous populations. I do want to share that in one of our clinics, I mentioned in Beatrice, Nebraska, so it's about 12,000 in that area, and it's mostly farmers and ranchers in that area, but the same practices that I do on our reservations, we practice the exact same way in our farming communities, and we've had such a great response with just the level of respect that people have felt within the session, because it's really about the relationship. And research will let you know that your clinical efforts, your clinical interventions are going to be more effective based on the relationship that you have with the clinician. And that's key to who we are as individuals for specifically for Indigenous people. So just wanted to make sure that I pointed that out. And then we'll talk a little bit about system change, because that's going to be the key. This has to be these changes that we make when we talk about cultural humility and embracing these things. We have to see that reflected in our policies and procedures. That's got to be from the organization as well. So just those are going to be some of the things that we'll discuss. These objectives are what we will how we will go through those. So we'll describe and identify challenges to cultural competency within the workplace. We'll identify strategies for incorporating cultural values and norms when collaboratively providing evidence-based practices. We'll identify available systems and the integration of culturally appropriate services, and identify at least 3 strategies for improving system collaboration for enhanced service delivery across communities. So one of the first things that I want to talk about is going to be all of these wonderful arts and crafts items that you have on your tables. So I want to invite everyone to create something throughout the entirety of this presentation. Part of this practice, and the reason why I'm doing this, is because within our culture, it's very common, it's almost expected to give. Within our culture, we give when we're grieving. We give when we're honoring somebody. We're giving if we want to move forward in something in our life, we're going to give. That's just a part of our culture. And the reason that is to provide, to share, to look out for our relatives. And by relatives, I mean all of us. We're all connected in some way. And so this is a part of how we take care of each other by giving. Now, within our culture, it's typically going to be kind of like basic needs things that we give away. And but it changes. And so, excuse me. What I want us to do is actually go through that practice and have you all experience what we do within our culture as we give away. And this is something that we do within our clinic. So this cultural practice is a part of our clinic, and it's so powerful for those that we work with. So for example, I'm going to talk about the trauma-focused cognitive behavior therapy. And after we have our relatives complete that treatment model, we honor them with the star quilt. We have a dinner with them and their family, or whoever they choose to invite. And that's not typical of a behavioral health clinic. But when you think about how we need to challenge the almost the scope of work that's done by psychologists or by clinicians, by substance abuse counselors, these are things, again, that go back to that relationship that makes such a difference. So yesterday we had a giveaway after our presentation, and so I did all of mine then, but I'm hoping that you all will be able to create something, and then we can talk about who you might want to give to and why. So we'll walk through that at the end as just kind of our final activity to wrap us up today. Okay. So cultural competence defined. This comes from the American Psychological Association. So it's loosely defined as the ability to understand, appreciate, and interact with people from cultures or belief systems different from one's own. As I mentioned already, we never reach cultural competence, and cultural humility and responsiveness are going to be the more appropriate terms that we want to use. The reason that we want to look at that term and incorporate humility in that is because we recognize that, yes, I may have my own beliefs, but I'm still able to learn from what your culture has done, what your culture has been practicing for years and years and years. So Dr. Thomas Friess, I had listened to him speak before, and he had mentioned, we have these evidence-based practices that have been proven by science to be effective, and that's been for the past 80 years or so. But then when we look at culture and the healing practices of culture, those have been around for thousands of years, So like if we take a step back and think, okay, 80 years versus thousands of years. Okay, I need to take this into consideration, bring this into my healing, bring this into the clinical work that we're doing. So I think that's really important for us as we move forward and as we kind of challenge the status quo with how we're providing service. So a little bit more with cultural competence. I actually have a couple of slides on cultural competence, but with humility as well. I do like this. It's almost operationalizing what we can think about when we're talking about cultural humility, or cultural competence is the term they use. So we have our beliefs and worldview, and this is key because when we come in with a really westernized worldview, we're going to have a bit more structure, not so much of that fluidity that we can see. And we'll go into a little bit more detail on that as we go through these other components of it, but that all fits into worldview. And where the challenge that we can run into is if I have this rigid view on, and I'm not saying that all Western is rigid, but when I'm rigid in terms of being able to see outside my worldview, that's going to have an impact on your willingness to accept the strengths from the culture, your willingness to accept your patient, your relative, your client, whatever term you use, as the specialist of their own life. And that's huge for us, okay? Because yes, I'm a specialist in my training. I know all of that, but I will never be a specialist in your life, no matter what you tell me. That's still your life that you live, but I can be here to support you through the training that I have and incorporate your own strengths. That's so empowering for people. So really want to highlight that with the worldview. Our communication styles, they can vary significantly. So sorry. One of the examples that I often use is eye contact. So eye contact varies across tribes. So within my tribe, when we have someone who is talking about something severe or traumatic, a very common response or almost an expectation that you would see from anyone sitting in the room who is of our tribe is we're going to put our heads down. So we're going to be listening like this. Now, on a different reservation, when that happens, I'm going to be making direct eye contact. I will be looking at them. I will be acknowledging what they're saying, but I have to be aware of that context of where I am, what's acceptable within this, and respond appropriately. So the communication styles, again, are very different. And the same would apply to the formality and the hierarchy. And now I'm going blank on his name, but several years ago, there was a study that was done where they were just regular students in college, and they wore these white lab coats. They had people agree to participate, and if they got something wrong, then they would get a shock. The study was actually to see how high the power of the shock would go, what the students would do, what the people would agree to. They would agree to more and more of those shocks because the person that was administering them was in a white lab coat. They had the authority. Okay, so that's something that we have to challenge, and going back to that worldview that you are the specialist in your life. I'm not here to cause harm, even if I have my training or those letters behind my name. You're still the specialist in your life. So we really have to look at that partnership and how we're providing services. And that removes that hierarchy. Perceptions of time can be very different. Sometimes it can even be about space. It could be seasonal. And this is something that I think is really important for us, even from a physiological stance, because when we think about how our body processes things, kind of like the body keeps a score, we're also going to remember things in terms of like seasonal. So for example, I'll use a personal example here. I already shared about the tornado that we had experienced, but every year around tornado season, I go through something. It's a little bit different for me, and it's different from year to year. And sometimes I might be a little bit more, I could get upset a little bit easier, or I might want more time to myself, but my body remembers that time of year. And so that's something that is also really important to keep in mind when you're thinking about cultural interventions and how we express our past, our histories, our knowledge. Really important things to keep in mind with a perception of time. The same would apply to values and priorities and the uniqueness and individuality. That one I think is also really important because, again, of the historical trauma that our people have experienced, the loss that we've had, with moving from being forcibly removed, having to walk. My grandfather, who I was honored to know, was 6 years old when they had to walk from Nebraska to Oklahoma. He remembered that. And so these things that happened in our history that the government did to us are not that far. If I'm connected to my grandfather, I knew my grandfather who walked, who was part of that journey. That's going to have a direct impact on me as well. And so that we had to hold on to what little bits that we could hold on to, because even practicing our spiritual beliefs was outlawed. It was illegal for us to do that. So you will see that families have held on to different things. And so across the tribe, even if it's just within one tribe, you're going to see those within group differences, because I had to hold on to this, but I didn't know about that. So I don't know if that's right, but that's what their family does. We don't do that, and that's going to be across the country, for any population. But I think it's very unique when we talk about what that looks like for American Indians. Okay, so a little bit more. We have this slide I do think is really important. This is feedback from Samson. It's talking about the assumptions. And this is where we go into the organizational commitment. So not just on the individual provider, the individual employee, the individual navigator. This needs to be from the organization. This has to be reflective in our policies and procedures. We have to have an understanding of culture and diversity and include those in our organizations. So, for example, for us within our clinics, we do a lot of partnership with mentors. We get a lot of feedback on different events that we have, but we also have people who are leaders in the community spiritually. And so it's written into our policies and procedures that if they are called upon to lead a funeral, they have that time off without any repercussion. They're still going to get paid. These things are hard with sustainability, but that is a part of the culture that is integrated into our policies and procedures, because that is who we serve. Our organization is reflective of that, or of that tribe, of that reservation. So that's huge. And we sometimes have it could be multiple funerals that can be back to back, and we're still going to give that individual that time to be there for those families, to be there for that community. And afterwards, I know that he's going to be very tired, and we're going to still encourage him, take another day or two off just to make sure that you're okay. That's the level of integration that we have within our clinic. So I think that it's a challenge when we think about it, and when you have to measure productivity, and there are those things that come into play from a business stance, but there are still those things that need to come into play from a human stance as well. I'm gonna have to get some water or something here. So incorporating cultural competence into decision-making, into all levels of operation, participating in diverse groups in development and implementation, public advocacy, trust in and from the community, and having a community voice in organizational operations. So for our various types of clinics, we can still bring in advisory boards, advisory groups. Oh my gosh, thank you so much. Let me have just a second, please. Thank you so much. So at any level, at any type of organization, we can always have an advisory group. An advisory group doesn't have to make the full decision. So the government, if we're talking about Indian Health Service or any other large hospital, they still have that authority, but they could be further educated. right? Because they're up there in their towers and making these decisions on what's best for us without actually talking with us. So it's about us without us, and that's not okay. So it's important for us to think about, how do we bring in that community voice? What does that look like? And who are those people that we need to be hearing from that are going to be representative of our communities that we're serving? So as I mentioned, there are definitely challenges to that, because when I think about this, especially as a private practice, if I have a clinician who's going to be out for a month, that's going to be a significant amount of funding. There's going to be an impact there. So we have to think, how do we make this work, and think outside the box in terms of partnerships as well? Okay. Now, as a provider and as a business, we have to recognize that there are those differing worldviews, and sometimes it just doesn't work. Sometimes people are not willing to embrace or understand or incorporate other worldviews into how they see things working. We had a clinician who was a very, very good clinician, put so much time and effort into the work that she was providing. But when she was following a specific model, so for example, the TFCBT model, which is a 4 to 6 month program or model of therapy, she was really frustrated in terms of how long it took to establish rapport. And according to the model, we shouldn't spend more than 2 to 3 sessions on that. And so we had to back up a little bit, because I'm like, well, it might take you 2 to 3 months. So let's just rethink that. And we had to really change her perception of time and following this specific model. And so that was a real challenge for her, and something that she was able to grow beyond, but it took a while. It took a lot of consultation. And I don't think it was ever anything that she felt comfortable with, which is fine. It just means she wasn't a good fit for us. So that those worldviews are going to be key when we're talking about the challenges that we have as providers as well, and as a business. Other things to think about would be things like dual relationships or cultural practices. So when we think about our small communities or our diverse communities, even within larger urban areas, there's still going to be the chance that, oh, I know this person. I did work with this person on this board, and now that person that I worked with on the board wants me to work with their kid, and so these different things can happen. But in establishing trust, in establishing relationships, and being part of the community, we embrace that, the dual relationships. We do discuss this with the person that we're serving. We discuss this in supervision, but we allow for that. Because again, going back to what I had mentioned earlier, that trust, that relationship is going to be so powerful in their belief in the intervention. So it's very important to recognize those. And then with cultural practices, this practice that we're going to do in terms of just having the giveaway to honor someone, that's very common practice for us, to give away, to have food with our to have food with our relatives that we're serving, and even just the way that we change language. So you're hearing me say relative. The reason that we say relative is because when we think about the relationship, specifically in a counseling setting, that's a very intimate relationship. That relative is sharing information about their lives. They're going into very private detail, things that they may feel shame about, that they're not able to talk with other family members or other support systems about. And we have to honor that. And we honor that by recognizing them as our relatives and giving them that level of respect. So we don't say patient, we don't say client, we refer to those we serve as our relatives, because that is an honor to work with them, to be there in that journey when they're trying to change their lives. They're trying to make good happen in their lives. What an honor to be a part of that, to walk through that with them. That deserves respect. That deserves recognition as a relative. So that's our perspective on that. The other piece is going to be the policy change and buy-in. As I mentioned, when we have things like productivity, you can't get around that. You got to keep your doors open. You got to pay your bills. That's where you look at what your partnerships are like. How do we get additional funding to make sure that we're providing quality care? So think outside the box. What other ways are we able to raise funds? What other grants can we look at? What other partnerships can be established with schools? We partner with schools that are getting grants, that are contracting with us because of the way we provide services. So, yeah, they could have any private practice or any clinic come in and work with their students, but they know what they're going to get with us. They know that we're going to bring culture into the session. They know that we're going to allow for prayer. They know that they can see ceremony happen within our session if that's what the relatives want. And so we don't have to worry about billing in some of those instances. We don't worry about productivity in that sense because we're there to serve that family. For a consumer, though, there can sometimes be challenges with that as people are, really trying to move to this of the cultural humility. And I think it's important for providers to keep that in mind too. So as a consumer, coming into a clinic and working with someone, I might be a bit more cautious if it's a non-native provider who's talking to me about smudging or talking to me about ceremony or encouraging me to do ceremony. And, there have been many things that have come up to where it's going to make it hard to trust. I had a video that I don't think I'm going to have time to show today, but a video of an individual who did a sweat, and he was charging like thousands of dollars to participate in this, and a number of people died in that sweat. And this was a Caucasian man, but he was doing it as a business, and you don't pay for ceremony, and so it was just very tragic. I want to say there were probably about 20 people. It was really horrible, and so that makes it harder. And so that's going to come into the session when we have non-native providers trying to talk to us about different ceremonies. Now that doesn't mean that we can't have a provider who's non-native, who's spending time in the community, who's known in the community and participates in those things. That's going to be different, but you have to have that level of investment. And then also recognizing community differences. For us, we work with one tribe on their reservation, and then 5 miles away is another reservation. They have very different beliefs, very different language, and we have to be aware of that. So it's really important to not lump everything together and see Indigenous people as one group. Remember those within group differences. We have across the nation, in terms of federally recognized tribes, we have over 570. There's over 200 different languages that are spoken, and there would be more, but that's part of the historical trauma and the loss that has happened. So just remember that there is some of the pan-Indian piece that happens, and there are many benefits to that. There are also those differences that you have to keep in mind. And then sometimes there's just that consumer rejection to where I prefer to work with a person of color. And we have to respect that when we do have those providers available. So those are some of the challenges that we can see as a provider, as well as from the consumer perspective. There are many benefits, though, as an agency and for our relatives that we serve. With the system perspective, the collaboration is going to be huge. That leads to also increased job satisfaction, productivity, and the psychological benefits, because there's a level of support that's there for the clinician. They feel more integrated. They feel safer with what's actually happening with the services that they're providing. It's going to help them actually feel a bit more like a specialist in the work that they're doing, because it's almost like a form of research that you're doing that's going to continue to inform you in the work. So a lot of benefits in terms of being able to embrace cultural humility for a system perspective. From a consumer perspective, a relative perspective, that collaboration is still going to be huge. When you're partnering with other agencies, you're actually going to increase the quality of care. So when you think about a holistic approach and thinking about the social determinants of health, if we have a relative who comes in and we know that housing is an issue, then who are we going to partner with to make sure that that's being addressed? If we know that they're having issues with getting to school, then what services, what programs are going to be available to help them in that? If food, basic needs like that are a challenge, where are the food pantries? How do we make sure we get them connected for that? So it's important to think about, again, those social determinants of health and who are we collaborating with? Move away from working with the silo in silos and working as a community together. The what we've also found is the trust and satisfaction with services when we're talking about embracing cultural humility, reducing stigma, and retention. And retention, I want to point this out because retention doesn't necessarily mean that we're going to see 100% attendance at every session. We can still have high levels of no-shows, but if something comes up when they are ready to start services, guess who they're going to come back to? Us. That's the retention that we're talking about, because there's that belief in what we provide. There's the trust in what we're doing. They know that there's going to be collaborative efforts. So retention is really talking about the long term and not that specific week to week attendance. Okay. With reducing stigma, this is another way that you can really challenge status quo in terms of what services look like. And, we've kind of touched on this a little bit in terms of being in our office and being that specialist that provides the treatment. But the stigma is so high, it's time for us to challenge that. It's time for us to come outside of our offices and be a part of the community, be at different events, participate in those events, and make sure that we as consumers, we as those relatives see you. You're not this, ominous person that's, hiding in the office. And it's important to be a part of the community. The other piece of this is you need to know who you're serving. And you know who you're serving by being out in the community, by being integrated into the community. So that's key. And that being that visible will help reduce stigma. And we're always talking about mental health awareness, bringing those in, talking about coping skills. And then it becomes the norm. And that's really what we want to push to. So thinking about get outside of my office, be a part of the community. That's huge. So it's really kind of changing what that schematic is for service delivery. With cultural practices, I'm going to go ahead and read this directly. So traditional and customary practices of particular ethnic or other cultural groups. Examples include religious and spiritual practices, medical treatment practices, dietary preferences and culinary practices, natural resource management, childcare practices, power relationships, governance, leadership, conflict resolution, and everyday life practices. That's a lot, right? As we think about all of those things that go into cultural practices, and this is going to be different from community to community. So it's important to take the time to get to know the communities, to know what those norms are. We had a panel yesterday where an individual had shared that one of the things that she did was served a certain type of meat that one of the tribes had revered, and so they couldn't eat that meat. And so she went through the steps to rectify that and made amends with them, and so everything was fine. But as she got to know the communities more, she knew about those things. So that was really important, to just be able to get back to what those norms are. So what we can do in terms of outreach and implementation is identify the key stakeholders in the community, look at cultural infused in daily operations, and a cultural audit of our clinic. So when we look at how we identify key stakeholders, who are they going to be? These can be leaders in our communities, of course, but I want to encourage you to think outside the box. Think about students, the youth, think about teachers in this as well, the parents, that's going to be key in determining how we need to do our outreach. How is this going to guide hearing from the voices in the community? How is this going to guide our service delivery? So really want to push for that. I've already talked a lot about building relationships and rapport and collaboration. Those things are going to be key when we're talking about identifying those key stakeholders and how we're improving the quality of care, because we can't do it on our own. This is partnership and relationship. Culture infused in daily operations. I'm going to start, we're getting close on time, so I'm going to start going through these slides very quickly. I apologize. So we have individual, organizational, program, and community level of culture being infused in daily operations. Within our tribal communities, if there's a funeral or the body is coming back, typically all of the tribe will shut down to honor that person's life. On the day of the funeral, typically the tribes will shut down. We follow that as well out of respect. That's a cultural norm that's there. So that's done at an organizational level. So there's, again, just embracing those things that are happening within the community. And it might be various holidays. Some holidays we don't recognize. So for example, Columbus Day, guess what? We're working. So those are things that, you have to think about when you're serving those communities. With the cultural and diversity audit. So how are different cultures reflected in your agency? When we think about some of our clinic spaces and how institutional they are, something simple that you could do is going to be just adding some color. Like, let's get some color in here. Let's get some paintings. Let's get different types of plants, but let's bring it to life. And so those are some of the simple steps that you can take to make sure that we're seeing something else. And when you have connections with those communities, bring in their artwork, bring in pieces of that culture into the clinic setting, and share the values of the community. So like we said, recognizing or not recognizing certain holidays, and making sure that the community is also reflected in your staff. And, for us, I shared this yesterday, we have like 6 to 10 Indigenous providers in our state. And so we have to think about that and in terms of, okay, how else are we going to be reflective of our community? We have other positions. It doesn't have to just be the clinicians, but other positions with say in how we operate our clinics. That's reflective of the communities that we serve. And then the cultural norms, again, being reflected in your agency. That can all be part of your diversity audit and something that I highly recommend agencies do. Okay, so this is something that I'm going to go through very quickly. And I don't get to share the video on here, but it's important to think about where people are in terms of their level of enculturation. So we have people that live on the reservation that have been there their entire lives that want nothing to do with the culture. But I live here, but I don't participate in any of the cultural practices. I don't go to sweat. I don't dance. And that's fine. That's important for us to understand and know where they are, because we don't want to try to make that a part of treatment if that's not a part of who they are. So again, making it safe for them and accepting them where they are. With this, we have, and this is an older study, but I think the way that they've described these different levels of enculturation are really good. So there's traditional. With a traditional person, they're going to be really rejecting Western society. Marginal is going to be where they're not really connected to either, not connected to their own culture. Bicultural is going to be where they're kind of like living in two worlds. That's something that you could hear us say, living in two worlds. Assimilated is where they're rejecting their own culture and have really embraced Western culture. And then pan-traditional is going to be pulling in from different cultures to form their identity. So I don't know if you all have seen Smoke Signals or Reservation Dogs, but there's some good examples of stereotypical things. The example that I pull from Smoke Signals is about how natives are supposed to be stoic. And that's how we should always look. And I had a psychologist that I worked with who had said that to me, like, I'm surprised at how animated you are, because Native people are really stoic. Like, get out of my face. That is not true. And as a psychologist, you should not be bringing in those stereotypes. So just really keep those things in mind. Nope. Okay. Protective factors are going to be key. Am I down to like 5 minutes or 2 minutes? Okay, here we go then. Protective factors. Keep these in mind with any organization, with any people that you're serving. Always look into those cultural factors. It can be those protective factors. It can be really difficult to see those at times. Sometimes even just coming in asking for help. Okay, they know how to ask for help. Let's build on that. Let's increase that skill. Let's strengthen that skill. And but these things specifically for our Indigenous population. So identification with the culture, their family, how extended families can be, and recognizing that, you know what, this is an uncle through their clanship system, and he's a very healthy person that has served as a role model. We're going to bring him into treatment. We're going to let him be support for this individual. The connection with the past, the traditional healing practices, adaptability. That's going to be for essentially all of us, because when we talk about the government forcibly removing us to pieces of land where we were not supposed to survive, and we did, we're still here because we can adapt. Keep that in mind. That's in our DNA. So please keep that in mind. That is definitely a strength. That is definitely a protective factor. The wisdom of elders and our spiritual orientation all can be incorporated into the work that we're providing and utilized as a protective factor. So the trauma-focused cognitive behavior therapy is a specific model of therapy that I was hoping to highlight, and I apologize for the timing here. This is a brief intervention that's evidence-based, but it has been adapted to the American Indian population. If you're not familiar with this, I would highly recommend going to nctsn.org. And this is done for multiple backgrounds, multiple ethnic backgrounds. It's been adapted to across cultures. So I highly recommend TFCBT. It looks at physical, emotional, mental, spiritual, and relational components. So I'm not going to go through each of those, but I will go to the next slide here. Just wanted to let you know how this is changing the face of therapy. With this, we are using specific cultural practices and how we're meeting each of those needs. So when we talk about self-regulation, okay, that can happen in sweat. When I go into the arena to dance, I can go in there when I'm upset and I'm going to feel the energy. I know that people are coming in there. Our songs are about prayer. I feel the drum. I dance with the drum. I dance with my relatives. And that's changing my thought process. That's changing what's happening in my body. And that's how we use culture to help us heal. That's so key for us to remember. With spiritual and relational, really thinking about the family dynamics, the community connectedness. You know, I talked about clans and clanship systems, and with our clans, how we have different roles that can also be used in interventions. So I had a time where my son was acting up, and through his dad, he's Bear Clan. So they're also like police. And so he was being mean to someone, and we had talked about, in your clan as Bear Clan, you're there to protect people, not bully them. And that was used in school to where if his teacher noticed that he was having an off day, she would let him see a picture of a bear, or she would hold it up so he could see. And he was reminded of who he was culturally, and that made a difference in his behavior. So these are the practical steps that I'm going to breeze through, but some simple things that you can do in terms of how you change the dynamic of your clinic. So thinking about when people are coming into our clinics, how are they received? Welcome them warmly, offer refreshments, listen to their point of view. And we've talked about that a lot. Oh, okay, my time is up. So let me have like 1 more minute. Okay. And then self-disclosure. Here's the other piece. Self-disclosure from you as the provider is important. That's frowned upon in our training, but that makes a difference because we are all connected. Go back to the relationship, use self-disclosure. There is clinical intent behind that. In fact, let me just tell you all about this study. So Thomas in 2011, best practices in counseling Native Americans. Please take a chance to look through this study. You're going to see specific steps on things that you can do as Native or non-Native counselors and things that you can change within your clinic. So if you were able to, she's making me nervous. I'm just kidding. Okay. So if you can please take those items that you have that you were able to make and give those to someone that it could just be, I just wanted you to know that I was thinking about you, and feel free to give those to those that you're serving. That makes such a huge difference in the relationship. Give it to a family member, give it to a colleague, and see what their response is, and know that these things are made with good intentions, and I'm sharing those good intentions, those good feelings with you. It makes such a huge difference, and that is a cultural practice that it can be incorporated into any type of job. Okay, so I'm going to breeze through those because I shared the name. This is the title of the article, Best Practices in Counseling Native Americans, from Thomas in 2011. And we will go ahead. We were going to also do a case study, but we won't have time for that. So let's go ahead and open it up for questions. Any questions?
Clarification. I wanted to make sure I got the org right for trauma focused CBT. Was it nctsn.org? Okay. Thank you.
Dr. Warrior, curious, all organizations, native org with coder words. He said,
You can't come in as a specialist without knowing who you're serving. So that's huge, and establishing that trust with the community.
Um, so yeah, I don't have a question. I just wanted to acknowledge and thank you for acknowledging yourself when you needed assistance and you recognize, hey, this is not working for me. And if it's not working for me, it's probably not working for my people. I'm become the change. So I just want to thank you for doing that.
Okay, there's a couple of questions or comments in the chat too. So one is somebody asked, how can we reach you? I don't know.
just Google me too. So Anitra Warrior, and you can definitely find my information.
So there's some information on the slides, and you can also Google Anitra Warrior as well, and some information in the chat as well. And then another comment is thank you for reminding us all to be visible in the community and not just reachable or found in the office setting.
Hi, thank you so much for this talk. I do addiction medicine here in Sacramento, California, in a pretty big organization. And I started here during the pandemic where they had kind of stopped all like outreach, for, some time before then. But I really like how you were speaking about, really like community being like the care and like community members really driving the intervention, not always being in the clinic per se. And I guess I'm wondering if you have any advice on the business case for a big clinic, and let's get the outreach out there. How are we going to, bill for these services and those kind of things? If you have any kind of recommendations on that, thank you.
So that's where we really have to think outside the box in terms of how we're getting additional funding. There are so many community foundations, private donors that will assist with that. So that's where the partnerships and the relationships happen. And it can be challenging because I know that there are always differing political views. And is this a political statement, and thinking about those things. But if you can partner, and it's going to look good. So let's say this large hospital partnered with this school to provide, mental health awareness. That looks good for both of them, and so it's a little bit of advertising too. So I think playing it from that role can be really helpful. Okay, well, thank you all so much for your time. It was a pleasure to be here with you, and I hope you enjoy the rest of the conference.